This is Dr. David Spiro for a new episode of HUMED or Human Medicine, where we try to talk about stories that folks in healthcare have and how meaningful those stories are and how it really relates to who we are as human beings, because we in the crazy world of healthcare have experienced stories, we experience trauma, we experience joy, all the different human emotions. And the goal of this podcast is to really talk a little bit about that. And I am incredibly honored today to have Sulagna Misra, if I pronounced that correctly.
Yes, you did.
And I'd like to call you Sue, and thank you for that. And welcome to the show.
Thank you so much for having me. Um, in an era where AI is dominating a lot of topics, it is so important to have human conversations. And so I just want to thank you for inviting me to speak and allowing me to speak.
Yeah, I'm honored. And you broke the record, by the way. I just got introduced to the idea of you coming on within the last 48 hours, and here you are today. So that is fantastic. And so I'm so excited to have you on, and um, would love to hear a little bit. Our audience, many of them are young learners, and would love to hear a little bit about your background and how you came to where you are today.
Sure. So I'm going to preface this by shocking everybody and saying I never wanted to be a doctor. Um, I actually wanted to paint and sing and do other things. Um, and when I was in college, my after I graduated, I took a year off. My mother and I came
Where
to
was
an
college?
agreement. College was
Where was
so
college?
I'm originally from I was born in California, raised in New York because my mother was also a physician. She was an allergist immunologist. She did residency there, so I was raised there. And then when I was in college, I did not want to go to medical school. Being in New York, I wanted to sing and create my own music and have an art exhibition. My mother and I kind of came to this agreement that I would take a year and go to a Caribbean school. And I would go until I didn't want to. And when I went, she got diagnosed with cancer. And she had ovarian cancer and already had basically, I went to the Caribbean, was there for a very short time. As soon as I landed, my computer broke. And I am not the most technologically savvy. And so I lost all of my music that I had produced. And that took a very long time. I was very disheartened by that. Right after that, my mother got cancer. And I said, well, she had a debulking surgery. And I was actually told by her brother that this already happened. And I had no idea because I was in the Caribbean. And she was given 6 months to live with
Mm.
ovarian surgery, ovarian cancer, bilateral. So she had an oophorectomy, bilateral oophorectomy and hysterectomy. And so, and we don't have a huge family history of cancer. But there's also a cultural component to that where my background is Indian and a bunch of doctors, and they don't go to the hospital. They don't go to the doctor themselves. So I don't know if this is genetic. And unfortunately, I didn't know what to do because if I don't understand basic medicine, how can I understand this severe, significant pathophysiology of cancer and of normal cells? So I decided I'm going to complete whatever short amount of time I have left at Ross University. That's where I went to school, and then come back because all of our rotations were in the US, and I will take care of my mom. By going back and learning some of the pathophysiology, she was given 6 months to live. I stayed home and took care of her and dedicated all of my second, third, fourth year of medical school to taking care of her. And then she lived an additional 5 years. So I
Wow.
ended up staying in Staten Island University Hospital, which is we're from Staten Island originally, whereas where she had her practice. She was also Dr. Misra. And she basically died in as soon as I started was it the end of my first year or my second year? She died in my arms. And so that whole experience, being a caretaker, being a doctor, being the daughter of a doctor in generational medicine, being alone through all of this changed the way I experience and practice medicine. I ended up after
So,
that. Oh, sorry, go on.
no, I was going to ask, how did that affect you specifically? Because we all go through various. I went to medical school in California. I went to medical school at UCSF, and I'm the first physician in my family, and everyone has their own unique experience going through medical school. And I'm just curious, um, how being a caretaker and learning about your mother's diagnosis and supporting her in the, I'm sure, multiple ways that you did, how did that shape your medical education?
So it was hand in hand, actually. She started chemotherapy in Staten Island University Hospital and was actually getting the wrong dose. So she ended up almost dying with an obstruction and a whole bunch of slew of other side effects. She then switched with my help to Sloan Kettering. And we found that she was just getting sicker. And I was like, can we do some kind of testing, just like we do with bacterial resistance? I was a med student then. I said, just like we do with bacterial resistance, can we do drug resistance studies? Because we're throwing all these medications at her and I don't know what's going on. Like things are not in remission. That helped change the trajectory of her treatment. If I had not gone to medical school and known to ask that question, she probably would have died a lot earlier. It ended up that all the medications they were giving her, she was resistant to 60, 70, 80% resistance. And even the combinations of medication she was resistant to. So it was like we were treating her, but not. So then we decided, okay, well, this is not working. Let's try radiation and stop the chemo because there were not these advancements in ovarian cancer that we have now. Back then, this is 15 years ago. And eventually we decided a different plan, palliative care and hospice at home. That changed the complete trajectory. So going to medical school gave me the language to advocate for myself and my mother. But being a doctor didn't allow me to feel the grief of the pain of losing her.
Mm.
And for example, I took a vacation where we're not given bereavement. I had 3 days of bereavement, and my mother was a doctor. They still have, I believe, yearly grand rounds in her name in that hospital. She was that precious and important to the medical system in Staten Island, and she did so much change there. Um, Sorry, lost my thought. This gets a little emotional for me.
Yeah.
um,
Well, I'll just, with that pause, I'll briefly share. I have not shared with my audience that I had a very traumatic experience with my mother's passing, which was also in New York in Westchester. And I don't want to get into the details, but um, one of the ways, and I wrote an article about it. It was actually published in JAMA, and I'll send it to you if you'd like. But what and I practice pediatric care. So I'm in a freestanding children's hospital here in Little Rock, Arkansas. I'm again, pediatric emergency physician, and we treat children differently than adults. And that's very clear. And it's a good thing, the way that we treat children. But I was very shocked by the fact that it became very clear that if there was not an advocate involved in my elderly adult mother's care, she was going to receive poor care. And that just doesn't seem right. And the one thing I found, the word I used in the article that conjured up for me from this horrible experience that I had around my mother's death, was that I think adult medicine in its current state today is a blunt instrument. And what I mean by that is that it's imprecise, and it doesn't feel right that the care that your mother received that you, as a healthcare provider, were able to change the trajectory of her care because of your knowledge and advocacy for her care. And it's even more profound because she was herself a physician.
yes. She actually was a pediatrics and then specialized in allergy and immunology, and she treated both. Exactly what you're talking about. I remember what I was going to say. Let me give you an example. So I was given 3 days residency bereavement, and then I went back to work, and I kind of couldn't do it. So I said, "Can I take my vacation early?" She was my whole world for a very long time, especially during her cancer diagnosis. Everything's revolved around her. So I ended up taking 2 weeks off. And then when I came back on to rotate on the floor, they put me not for 1 month, but 2 months back to back on the hemonc floor. And I was like, can you give me any other floor? People don't want to do the ICU and CCU right now because the rotation amount is Q3, Q4, where you're on call overnight every third or fourth night. I was not sleeping because of grief. I said, give me that and give someone else this hemonc floor. My mother just died of cancer. You're putting me here not 1 month, but two back to back, where she was admitted many times in this hospital. And I just couldn't fathom. But that is what the system does to us. And no, I could not get out of those rotations. I did them 8 weeks.
That's brave and courageous. How did it go for you being on the cancer floor? Was there a healing process to you, or do you feel like you experienced some degree of trauma being experiencing that?
It was all trauma. um, there was only one time that was healing, and I was on call, and something happened where the bells went off, and I went to the room, and there was nobody there. And then I pulled up who was supposed to be in that room, and it's supposed to show up as green, and it was my mother. So that was a very weird after she passed experience that I had on that floor. But mainly what I had was repeating and reliving her process of end of life over and over again, and the entire cancer experience. And that is what I didn't want. Um, I wanted to disassociate into the medicine. And instead, I had to be faced with the pain of the grieving family and the shock sometimes of this new diagnosis and how quickly sometimes life can be taken.
Yes.
It was just re-traumatizing over and over again.
Well, first of all, like with many of our guests, I'm incredibly appreciative. We just met today that you are open to being vulnerable, because that's a very vulnerable story to share that involves a mom that you obviously love very, very much, and a very difficult time in your life. So I'm curious how this was during medical school. What did you end up pursuing a residency taking care of adults?
So this was actually during residency. Um, I was already in residency. I was in internal medicine. Um,
Mm-hmm.
I actually changed what I was going to do so I could rotate and do my any residency basically in Staten Island as long as I could stay home and take care of her. I would have done anything. And did get into internal medicine. Many times I thought I want to do palliative care, I want to do hemonc. All of that kind of went away. I think what ended up happening is I was too exhausted to do fellowship. And tired of the grind and the exhaustion and the burnout that comes with not being treated as human when you're a resident. And that is evidenced by how they put me on that floor with me begging. I will go to the ICU and rotate every other night. Like I barely sleep. Please put me elsewhere, and not being heard. So there's a lot of things that taught me in my life. And if you ask me how I did it, I could not do that again now. No way.
Hmm. I appreciate that. My residency was every third night, and when I did it, because my residency was in the early '90s, and I think it's better, but there's still a long ways to go in terms of providing support and wellness for our learners who are in training. And I think there's a lot of lip service that's done around wellness, and it's much harder to do than to say in
Yes.
terms of uh, prog- programs in medicine, whether it's internal medicine, pediatrics, you name it. It's worse probably in the surgical fields, um, to promote wellness in a time where we're learning, but it's also incredibly stressful. And we've talked previously on this podcast that when you are a learner and you are not only being a learner, but you also experience significant trauma, it's very common to have for all of that to disrupt your sleep. And what we know about, because I've learned a lot and I've shared with my audience a little bit about the longevity space, and that sleep uh, is thought in some ways to be optional. And I learned zero about sleep in medical school, like literally zero, and zero in residency. And I think it's zero still now, or close to zero. Yet it's one of the core pillars of health, is to make sure that we're all getting enough sleep, and it's challenging when you're a learner and supporting that. What are your thoughts
Yes.
about sleep?
Gosh, I love sleep. It doesn't love me back. And I think I
Mm.
think that a lot of us struggle with that. Um, this furthers my story, actually, my own story. I ended up getting into Mount Sinai as a hospitalist. That was my first job out of residency, and I started out as a nocturnist, um, thinking, stupidly, well, I did residency and we had short call and then overnight shifts. That's why we didn't do a Q3. We had quite a large graduating class, a large residency. Um,
And for those
and
learners, for those people that don't know, Mount Sinai is one of the top 3 or 4 hospitals in Manhattan, in the metropolitan area. It's an outstanding
yes,
institution. And anyway, so go ahead.
it is excellent. Um, the problem with Mount Sinai for me was that I would be a hospitalist. And so everyone would constantly say, you know what, I just want to talk to my primary care doctor because I
Mm.
don't know, you're here in the hospital. A lot of times being a woman and being petite, I would be confused for the phlebotomist or the nurse. So I'd be like, no, or they'd be like, I never saw my doctor. What are you talking about? I'm like, I'm your doctor. No, let me speak with my primary care doctor. I have to confirm what you're saying is accurate. And then I realized I want to be the primary care doctor. I don't want to be the one they see admission after admission. I want to be the one who prevents them from getting back in. And I want to be the one who knows their story while they're in. So I ended up leaving Mount Sinai and joining and helping create, although it was not mine, integrative medicine of NYC. If it was not for integrative medicine, which I think didn't then barely had a fellowship, um, I went a very non-traditional path. If it were not for integrative medicine, I think I would have quit medicine a long time ago because integrative medicine is where I learned nutrition, sleep, hormones, Maslow's pyramid, sex, play, rest, different types of rest, heart, brain, gut, connection, and everything that makes us human and whole. So I think integrative medicine should be integrated into medicine.
Yeah.
Yeah.
So just for the audience to know, a hospitalist is someone that cares for patients in the hospital. Patients are in the hospital for different reasons, and there are usually floors and floors of major adult hospitals where, and this didn't exist when I was in training, but it's developed into its own specialty. So it sounds like, Sue, you actually went from wanting to be, if I could put this in some other terms, to be a physician where you were being reactive to the care, to wanting to be proactive in the health of your patients, and health being a different mindset than what we learned in medicine. Is that a fair
Yes.
statement to say?
Yes. I think, sadly, my mother's suffering gave me an extra degree in trauma and grief. and what is missing in medicine.
So, can you explain to the audience, because two of my colleagues in pediatrics here at Arkansas Children are just about to finish their integrative medicine fellowship. Oddly enough, one of them is a peds ER physician like me, and the other one is a clinical informaticist who has always had a desire to do the work you're doing, and they're completing their integrative medicine fellowship in Arizona from Andrew Weil, I believe his name is, and I've read some of his books. And so they're it's remote, but they go to Arizona every 3 years or 4 months or so. And we just started an integrative medicine clinic here for children. And within 1 month, it's only 1 day a week. Within 1 month, it's full and has a waiting list,
Yes.
which is really interesting to me. And I have no doubt it will be a everyday clinic because of the needs of at least within the sector of pediatrics. But I'm curious what you mean by integrative medicine and how that's translated into the work that you're doing now.
So I actually had another death after my mother. I actually had a succession of deaths, unfortunately. While I was working in integrative medicine at NYC, my father died, and my body actually gave up. I thought I was having a heart attack, and I could not work. Um, because it was not my practice, I couldn't get someone else to cover it. It was very difficult. I ended up leaving New York, actually moving from New York and coming to California to heal. When I first came to California, and by the way, my practice is called Misra Wellness. And I came up with that on a napkin while I was like, oh, M&W. But back then, wellness was not watered down. You go to yoga and then you go take these supplements and then you take this and you'll be fine, 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 essential oils. What I'm learning is what we need as wellness is also witnessing what we're doing right now, discussing our stories, humanizing medicine, and doing pretty much everything we were taught not to do in medical school, where we are 500 or 5,000 of us for one position pitted against each other and said, okay, everybody, there's one position, go. And you're feeding each other wrong information, so they fail the test. I mean, I've had people do this to me, and instead we learn to collaborate later around a patient, but we need to collaborate around medicine and ourselves and all of our patients collectively. What we're seeing now and why your practice is probably full and will be full is because people are not feeling heard. That is why part of the reason they're trying to track all their data. I actually wrote some pieces about all this, piecemealed it. Datafying yourself instead of identifying the person, being seen as human. As a patient, we come in with all these metrics. My heart rate is this, my sleeping, resting heart rate is this, like this is this. But we're trying to say something else. And that is the piece that's missing in medicine. Well, why are you tracking? The curiosity that we entered medicine to begin with is also kind of creamed out of us. I don't know what to say. We end up just being algorithmic. And we're not AI. That's what makes us so special. We have the ability to combine experiences. So in my practice, while I'm integrative medicine, because of my experiences, it's more of a mental health approach versus some other integrative medicine physicians, maybe largely infusion, supplementary, let's add acupuncture, let's do all the testing in the world. I'm a little bit different. Yes, I do gut microbiome. I believe in maintaining that health. I believe in supplementing, but I believe food is medicine first. Let's start at the foundation. And I also believe everyone's start place is different. So some people are sitting on the couch from medical trauma suffering, not able to go to the doctor and see me because I can do virtual care. And our goal is to get them to the doctor with empowering. Other patients don't know how to maneuver through the doctor and the insurance system, which I left. And I'm a direct primary care doctor, and we can talk about that separately. And they are asking to be seen in a different way. direct primary care is a movement where you can be family medicine, geriatrician, psychiatric, and because it's one monthly membership fee, it's more relational instead of transactional. You don't have to think, oh my gosh, this is going to cost me $75. This is going to cost me $500. This is going to cost me $200. If I go ask the doctor this or whatever, I'm going to be hurried. I'm going to be rushed because they only have 15 minutes and they're on the next patient. All of that from the algorithm gets taken away. And what is left is real medicine and real relationships and real change.
I really appreciate that. So I've learned a little bit along the way about direct primary care. I'm not as familiar with it because I'm in a pediatrics world and in an area here, at least, where there's not much of it. But I recently came from within the last 5 years from Oregon, where it was kind of taking off. So
Yes.
is this kind of a practice where you limit the number of patients that you have? So you'll have a panel of 500 patients or whatever the number is, and then that's it. And your job is to take the best care that you can of that group of patients. Is that a fair assessment?
Yes. It's also become more than that. We are individual small businesses, and direct primary care also is a movement by physicians for patients. We are also trauma informed. And I say that because we are physicians that have selected to leave the abusive system of medicine that does not validate or treat us, and especially our patients. We are sick of fighting the insurance system, demanding that our patients get care. We are sick of not getting paid for our time and the complexity of care that we offer. Can you still hear me? Because I can't see you.
I can hear you perfectly.
Okay, there we go. Oh, let me see another screen. So collectively, direct primary care is individual physicians that do comprehensive care. And we limit our panel so that we can give all the attention that we can give without rushing for those patients that we have. And then I do medical weight loss and men's health. I kind of call those tiers a taste of me because they're very popular and people will pay out of pocket because often they're not covered by the system anyway, as system is losing money from covering these, and we found that out. So once they get a taste of me, a lot of them then upgrade and I become their primary care doctor. I don't like to force someone into paying money without knowing that they want to. In a regular insurance system, you don't have something called a meet and greet, which is what most DPC doctors do, if not all. And the reason we do that is because we want to make sure that we as a physician can meet the patient's needs. So I had a meet and greet with my own DPC doctor.
Mm.
And that was so important because if I didn't feel heard and I felt re-traumatized by all the medical trauma I myself have gone through with my mother, misdiagnoses and things along the way of her cancer treatment, I would not probably keep up with my own care. So
So you had said a bunch of things, and I think that we're going to have you on again, because I think honestly, I see eye to eye to you, and I think we're kindred spirits on so many different levels. But you used a term called trauma informed. You
I just got
practice
chills.
that, and can you talk a little bit about what you mean by trauma informed?
So the medical system is traumatic. It is. Our training is traumatic. It is an abusive system. It is a hierarchical system. And it is missing so much. I can just start with the most frequent complaint of most of us graduating. We get no business education. Forget about we get nothing. We don't get the basics: business, nutrition, sleep, sex differences, and sexuality, which is now going to be a fellowship, which is being promoted by a lot of our physician colleagues right now, as evidenced by this recent FDA removal from the estrogen, sorry, not just vaginal estrogens, all estrogen contained products. These things are important because they are all related. One of the physicians who helped get this black box warning off of estrogen did it because her mother almost died from something very treatable and preventable. And her story swayed the FDA. Our stories are so important, more so now than ever, when everyone is lacking community. And what direct primary care being a national movement of trauma-informed physicians, because we refuse to stay in a system that continued to harm us. Therefore, we left the system for safety, and we train our patients sometimes by doing. Right? I left the system, so some of my patients know Dr. Misra left. She's okay. I can maybe do some things and leave this abusive situation too. And I guide them in that. That's where I said I'm more mental versus I really try to dig deep with my patients and go places that we don't go unless we feel safe. And
I
that is why I love
appreciate that.
DPC.
No. I think the model is brilliant, and I have no doubt it will become more exponentially available. But from my understanding, again, you have a limited panel, and there are only a limited number of internal medicine physicians that exist. So how is DPC not going to sort of level off because you have a panel of, let's say, 500 folks, and if you do the math, that's just going to cover 1% of the population that can afford it. So how do you see the future of DPC developing with that limitation?
It's already happening. Word is getting out that we call it a DPC wave. I think it's going to be a tsunami. So unfortunately, we've had a chaotic year economically and a chaotic year with healthcare. And I myself have my own healthcare cancer scare, nothing covered by insurance, paying everything out of pocket on top of my premium story. Where I hemorrhaged money trying to get diagnoses and figure out if I had cancer and denial. But I'm a doctor. I helped my mother through this. You telling me you're refusing my MRI, I have to pay out of pocket when I literally check. Everything is I meet the standards for the MRI and I know what they are. That is when this year I decided I'm dropping insurance myself and I'm going to health sharing. So, and that's a whole conversation in and of itself. Alternatives for health insurance that people don't know. But what people are realizing is there is a movement of physicians. And the most important thing is getting the word out at so many levels, at the patient level, at the state and federal level, which they're already aware of this, by the way, this movement. And it's in this bill as of this year, how much money you can use from HSA and FSA towards the DPC doctor. Marketing. Getting on podcasts and talking about this movement, having influencers experience this movement. And my favorite, which I'm desperately trying to do and give back to my own residency, who never taught me business, is that there are other options than just sticking with the hospital or joining someone else's practice. You can make money, have boundaries, and make sure that patients receive care, which is why we're doing this in the first place. They're seen, they're heard, they're witnessed.
You had also mentioned that food is medicine, and that really resonates with me. I've learned a lot through my own longevity journey on how processed foods and ultra processed foods are just can promote disease, and sugar and sort of the standard American diet. So I'm curious what you mean by food is medicine.
Supplements should be supplementary, meaning they should be targeted and curated on top of what you're already putting in your body. So first, food is medicine because it is the building block of what creates you. And if we start with food as medicine, how are you eating? Chewing, even just smell, joy. What kind of feelings do you have? Or is it panic? Or are you eating from a place of instead of eating with intent to? Are you absorbing the nutrients that you are eating? A big one, big one, especially since we're the first generation of obese, micronutrient deficient humans. How did that happen? That itself is very important. And when we're talking all about these micronutrient deficiencies and stuff, I always say, well, let's start with what you're eating and if you're even absorbing it and how you're eating. And are you chewing or just swallowing the food? And then is it causing chest pain? And you're, oh my God, everything gives me chest pain because the bolus of large globule of food is sitting right at the esophagus, which you cannot even allow to go down. There's so much complexity involved in food. Why do you reach for that? And I treat with these GLP, GIP medications all the time. One thing they allow is it's almost like a medical mindfulness where you get a pause before you, I've been on these treatments, which is why I can say this. You get a kind of chance to reflect about what you're going to eat before you put it in your body. And that kind of has been taken away by muscle memory. I'm going to eat this. I ate this last time. I can eat this time. I'm going to have 2 of those. Those look small. Already decided before we even put it in our mouth. This is integrative medicine. This is mental medicine. This is emotional medicine. We didn't even get to the medicine of medicine.
Well, we are wrapping up on our time, but I want to say that you're my hero. We again just met today, but your story is heartfelt. I'm so incredibly appreciative about your vulnerability and your path to where you were to where you are now, and the work and the mission that you're participating in is to me so incredibly meaningful and courageous, because you're doing something that was not taught in medical school, and much of it now has been self-taught, and also being a part of a movement that clearly needs to happen. It's almost seems obvious to me, based upon the experience and the trauma that I experienced with my mom's passing, and clearly what happened with your mom. So I would love to have you, Sue, back on the program,
I
and
would love
thank you
to
so
be
much
here.
for sharing.
Thank you for having me. And there is one thing I want to end with, and that is it is so important to teach the younger generation. I think they're eons ahead of us already in many ways. Maybe they've been forced to grow up very quickly. I'm constantly amazed by this youthful generation and what they're capable of doing and the changes they're making. But we need to get the word out because people are exhausted from medicine and they don't see another way. And that's what I want the message to be, because you cannot be an exhausted physician and then give all of yourself, which is negative, to the patient. Because we are human, we are limited, we're finite, but we treat ourselves as if we're not. And how we treat ourselves rubs off on the patient too, and they feel it and they see it. So we have to learn to take care of ourselves in multiple ways. And getting the residents and med students involved is probably where we really need to start the healing.
Yeah. Well, you're an incredibly passionate human, and your patients are incredibly lucky to have you as their physician. And so thank you again for being on the show. For those of us that are listening, we just passed 1,000 YouTube subscribers. I look forward to the day where we could say 10,000 or 100,000 or 1,000,000, but we're at 1,000, which is a mark that our editor Ty says is a critical junction. So we're really happy about that, and we're unfunded, but we also are bringing on amazing guests like Dr. Misra. And please subscribe if you're watching this on YouTube or Spotify or wherever you digest your podcasts. And I hope that you all have an amazing day. Thanks for joining.
Thanks for listening to HUMED with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.